I say perimenopause is like the inverse of puberty. Puberty's happening, hormones are all over the map, but they're like increasing, and perimenopause, they're all over the map and decreasing, and sometimes they're just low overall.
Right.
So, doing testing will help us identify that, and will help us identify also, like, does a woman have really low estrogen, or is it all over the map? And then symptoms are really the most important. And the amount of flow, like how heavy your period is, can be a very helpful indicator of what's going on. For women with the IUD, it can be trickier because we don't really know. Sometimes they're not ovulating. Very often they're not ovulating. So I'll check their labs like 10 days apart. Symptoms are a huge part of it. Of course, labs are not the primary way to test for perimenopause. There is no definitive test for perimenopause. I think labs are critical. And also because I have coined this term, the unmasking effect in perimenopause. And what that means is perimenopause is a time when any underlying health condition gets unmasked.
Hello and welcome back to the Smarter Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. So today's podcast was a fun one with Dr. Christine Maren. Christine's actually a neighbor. She lives locally, and she's a family medicine doc that has a virtual functional medicine practice that focuses on menopause and perimenopause. And Christine is actually going to be speaking at our Health Optimization Medicine and Practice Symposium happening October 17th and 18th here in Boulder, Colorado. Check it out at homehope.org. And so Christine and I had a great conversation. Let me give you a quick bio of her before we get started. So she is a board certified physician and founder of a virtual functional medicine practice here in Colorado, Michigan, and Texas virtually. She was introduced to functional medicine after struggling with pregnancy complications and recurrent miscarriages. Now mother of 3, and she's crazy like me, getting people everywhere to camp this summer. She devoted her professional life to helping others address the root causes of symptoms, to restore health, prevent disease, and get their life back. She earned her medical degree at the Chicago College of Osteopathic Medicine of Midwestern University, and later moved to San Antonio, Texas, to train in one of the nation's premier family medicine programs at Christus Santa Rosa Hospital. She spent some time in Tucson studying with Andrew Weil at the University of Arizona Integrative group over there, and Dr. Weil is known as the father of integrative medicine. She was later introduced into functional medicine to address her own concerns, and she has her own functional medicine practice now, virtually working with people in Colorado, Michigan, and Texas. And so I've known Christine for about a year and a half. We met at an event in Boulder, and she's super smart and really, really good when it comes to perimenopause and menopause. And we talked a lot about, various things in this podcast, but we started off talking about the gut microbiome and perimenopause and menopause. And many people don't really understand the connection here. So we talked about how estrogen plays a huge role here, how the estrobolome or estrobolome plays a huge role over here as well. Leaky gut, intestinal permeability with hormonal changes, with the variations in progesterone and estrone. We talked about the lack of bifidobacterium and lactobacillus that happens as hormones are changing for women starting in their 40s, and how keystone species otherwise like Akkermansia can also be modulated and changed, hydrogen sulfide or rotten egg smelling gas, and how this has effect on the gut as well as insulin resistance. Then we also went from there to talk about different types of perimenopausal symptomatology or spectrum, one from a variations in estrogen and one from a more of like a low estrogen dominance, where you have the latter category in people being more high cortisol and have higher A1Cs, interestingly enough, even though they're not insulin resistance. We talked about unmasking. When you have your hormones change during menopause and perimenopause, you can unmask symptoms and autoimmune conditions like Hashimoto's thyroiditis or other autoimmune conditions as well. Gut dysbiosis and how you manage that. We also talked about HRV in detail, HRT. HRV is related to your heart, and HRT is hormone replacement therapy. How she does it, what kind of testing she does, how she tests things over time, and the idea of how you can modulate not only hormones, but also her whole framework looking at root causes as to why hormones might need to be looked at sort of course, but secondarily to looking at heavy metal exposure, toxins exposure, vitamin, mineral, nutrient, cofactor deficiency, and then other things like mindset, exercise, and things like that. So this is a wide-ranging conversation with Dr. Christine Maren. I really enjoyed how she broke everything down, talked about the subjective aspect things, the clinical aspect of things, the testing aspect, and how you can really work on this as a clinician and as a patient or as a woman going through perimenopause and menopause, how to kind of navigate some of these things. So I hope you enjoyed this podcast with Dr. Christine Maren. Don't forget that we have our Home Hope Symposium coming up October 17th and 18th. You can check it out at homehope.org. Christine will be speaking. Now, without further ado, this podcast with Dr. Christine Maren. Christine, how are you?
I'm doing great.
I know you're only like 5 minutes away down the street in Louisville today, right? So
Yeah, we only talk virtually though.
that's how it goes, right? As clinicians and as busy families with lots of children, it's a challenge to get out of our house or to get out of our house other than taking our kids to summer camp, right? So
that is exactly right. We will see
well,
each other in the car.
Yeah. So Christine, it's really good to see you. So for those of you who don't know, so Christine and I, Dr. Christine Maren, thank you for being here. We are neighbors. We actually met at an event here in Boulder relatively recently, about a year ago, I would say, right? And you happen to have the last name that's the first name of one of my daughters, so I'm saying your name appropriately. I know that you can get it kind of butchered as a result of various reasons, depending on where you are from the country and what kind of accent you want to put on it. But Dr. Christine Maren, and I know you have a fantastic platform, and I wanted to bring you on for a couple of different reasons. First of all, to talk about gut health and menopause, is I think it's a really interesting topic, and many women and men, of course, and clinicians don't really know about the connection here. So we're going to go into detail. And I'm also excited that you're going to be speaking at our Health Optimization Medicine and Practice Symposium on October 17th and 18th here in Chautauqua in Boulder, which, thank goodness, is one conference that we don't have to travel for. I know that traveling is difficult for the both of us, but we do it often for work, and sometimes our kids get to come along with us as well, right?
Yeah, I'm just glad it's not in Vegas.
Oh God, yeah, I'm going to Vegas next week for another conference.
It hurts my soul.
I know. Yeah, we did our last symposium in Vegas right before A4M in December, and that was just a bad idea overall.
Yeah.
So, okay. So today, Christine, I want to talk about gut health and menopause. And so maybe you can frame it for us a little bit before we get into specific questions. Not something that people would typically think about when menopause is happening, right? We know that, that hormones are changing. Tell us a little bit of what's happening in the gut as menopause is starting, as perimenopause is starting, and then how this potentially has like a bidirectional relationship between our hormones and how they may be coming down fast or slow, depending on what's going on in the gut itself.
Yeah. So everyone knows that perimenopause and menopause is largely about hormones. And my message is it's a lot more than just hormones. There's huge changes that happen all throughout the body. And one of those primary changes is in the gut microbiome, which, as emerging research shows us, is really important for all sorts of downstream effects from inflammation, autoimmune disease, food sensitivities, you name it. So what we now know is that during perimenopause and menopause, a woman's gut microbiome indeed changes along with hormones. And the thought is declining estrogen leads to decline in intestinal diversity. And that really affects a lot of things, including permeability that we'll talk about. But we see that a woman's gut microbiome plateaus around age 40. And there are sex differences in a gut microbiome. So the male and the female gut microbiome look very different. A female gut microbiome has a lot more diversity until she reaches menopause.
Compared to men. So compared to men, it's much more diverse until the age of 40.
Exactly. Okay. Yeah. And then it starts to decline from 40 on, largely because of hormonal changes. And as that happens, when a woman reaches menopause, her gut microbiome is much like a male gut microbiome. And that has a huge effect on the way that she metabolizes hormones. So there's this very interesting bidirectional effect where hormones are affecting the composition of the gut microbiome. And in turn, the composition of the gut microbiome is affecting the way that we balance and metabolize hormones.
Is it just estrogen that we're considering here, or are there any other major hormonal implications here, like progesterone or even testosterone, which might have an implication on the male side too?
Yeah, they definitely play a role. I'm not aware of any really great research on testosterone with regard to females. I think there is some limited, but with males, but I don't know it as well. There is, progesterone we know plays a role. I think a really great way to look at this is just in pregnancy. We see when women are pregnant, they have a really high amounts of progesterone and estrogen. And we know
Hmm.
that women also have slowed gut motility related to the high progesterone.
Of
Progesterone
course.
kind of relaxes everything.
Yes.
And so it definitely plays a role in the gut. I think it doesn't play as large of a role as estradiol, or at least the research doesn't show that.
Hmm.
But yes, I'm sure they all play a role. And I'm sure testosterone plays a role. We just don't quite understand it yet.
Understood. And so, from a diversity perspective, what's happening here as far as the microbiota species themselves? Do we have a sense of what changes, or what are the major changes overall, and how maybe estrogen has a role here?
Yeah, Bifidobacter lactobacillus species decrease, and then we
Okay.
see increases in some of the dysbiotic species. We also see a decrease in Akkermansia. So,
Okay.
with that dysbiosis or loss
Hmm.
of diversity, as I explain it to my patients, it's like, you have a parking lot, and you know, all these parking spaces are now empty and
Hmm.
are filled with the bad players, which could be bad bacteria, but also might be yeast or fungal overgrowth.
Sure.
And a really interesting one in perimenopause is that women often get overgrowth of the species that produce hydrogen sulfide, which
Oh,
hydrogen
fun
sulfide
times. Yeah.
is can be toxic to the enterocytes or the cells of the colon. So that is, definitely an overgrowth that some women will experience, but I think it can be really all over the map.
Gotcha. Well, let's talk about hydrogen sulfide. What is it famous for?
I mean, hydrogen sulfide SIBO and rotten egg smelling
Yes,
gas.
that's what I think of. I think of very, very bad
Yeah.
smelling gas is the
Bad
hydrogen
gas, lots
sulfide.
of bloating. It causes a lot of inflammation and then it can also disrupt metabolism. So it's
Hmm.
associated with weight gain.
Is it? Is it? So is it associated directly with insulin resistance as a result?
Yeah.
Interesting. Interesting.
Yeah.
And so I know with Bifidobacterium lactobacillus, like those are the two most common species in the gut overall, correct?
Uh, some of the most. I mean, if
Some of
we
the
look
most.
at
Yeah.
keystone species,
Yeah.
right?
Yeah.
Akkermansia is a big one,
Yep.
Bifidobacter lactobacillus. I mean, E. coli, you're gonna, yeah.
Gotcha. Yeah, I think of when I think of Bifidobacterium lactobacillus, I think a lot of the GABAergic nervous system, oftentimes,
Hmm.
because I know that Bifido and lactobacillus are very correlated with um, GABA production in the gut, as far as I
Hmm.
understand, and how that regulates the vagus nerve and how that regulates brain function related to the GABA itself. Do we think? I mean, there's a lot of things that are happening during menopause, of course, right? But
Hmm.
is that potential another cause of why maybe there's more irritability, there's more sort of glutamate toxicity kinds of
Yeah.
symptoms related
Yeah.
to the menopausal
I would
timeframe?
definitely think so. I always think it's kind of like this vicious storm. That's
Yeah,
one of the reasons.
totally.
There's a lot of different reasons: declining estrogen and imbalance in estrogen and progesterone. Histamine's also a really interesting one. We see
Okay.
increase in histamine during perimenopause. So, progesterone pretty much universally declines in perimenopause, and progesterone stabilizes mast cells,
Okay.
and mast cells release histamine. Also, some women experience these really high estrogen spikes in perimenopause, and it's high relative to progesterone, which can
Mm,
destabilize mast cells. On the flip side, low estradiol can affect the immune system, which can not be favorable for histamine. So, anyways, histamine can cause a lot of issues. Typical kind of stuff is hives or
right. Right.
allergies or, allergic rhinitis or something like that. But it can also cause headaches and irritability and anxiety because it's
Mm,
also an excitatory neurotransmitter. So, I think that's a piece of that puzzle too.
I see.
And then like women aren't sleeping as well. I mean, I think there's just so many different reasons why women might feel more irritable during this
Right.
time of their
Totally.
life.
Right. And progesterone's going down too, as
Yeah,
well. And progesterone is going to work on the GABA system at the same
exactly.
time.
Yeah.
So histamine intolerance or histamine sort of increases comparatively. This is all related to estrogen dropping. Is that correct? Or is there other
Yeah,
reasons?
it's related to it's really related more to progesterone dropping and to
Ah,
an imbalance between estrogen and progesterone, which is what people usually refer to as estrogen dominance. But if you
understood.
have too much estrogen relative to progesterone, it's sort of like you've got both problems. You've got low progesterone,
Okay.
so progesterone stabilizes mast cells, and then you've got high estrogen, which is releasing more histamine.
Got it.
Or on the
Okay.
flip side, you might also be I talk about two types of women in perimenopause. One type is this woman who has low progesterone and these chaotic fluctuations in estrogen. So it'll be like high, low, high, low. And that's what most people talk about in perimenopause. However, there is a type 2,
Hmm.
and I see this a lot clinically, and she is a high performing female who has low estrogen overall. And she doesn't really ever experience those big peaks. She just has low estrogen and low
Mm,
progesterone overall. And so that affects the immune system. Low estradiol. I mean, estradiol is really great for us. Estrogen's a really wonderful hormone. But when we experience low estrogen, women have a lot of symptoms related to that.
yeah. So interesting. There's two sort of major types. I'm sure there's probably crossover too, where people might start one way and go another way too, right? And there's never one or the other in clinical medicine, I like to say.
Yeah, totally. I mean,
Yeah,
what what everybody talks about in perimenopause is that type 1, where it's this very chaotic estrogen and it's not
right,
balanced by progesterone. What I'm talking about is this type 2, because most of the patients I see are high performing women
right.
who have really suppressed a lot of their HPA axis.
Part of the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our Home Hope Symposium happening October 17th and 18th at Chautauqua in Boulder, Colorado. We have 2 days of speakers. Dr. Christine Maren is one of them. There'll be CME credits. You have Dr. Christine Maren, Dr. Chris Shade, Dr. Elizabeth Yurth from Boulder Longevity, Thomas DeLauer, Dr. Abid Hussein, yours truly, Dr. Scott Scher, Dr. Ted Achacoso, and more. So check it out at homehope.org and come join us for the symposium in beautiful Boulder, Colorado in October. And now back to the show.
A lot of the women I see are very, they've disconnected a bit from their body and
Mm,
pushed through. They've learned how to like perform and push really hard. They might be like, a lot of them used to be athletes, or they're still, athletes, but they're athletes when they were younger, or
right.
they're CEOs, or they're just like really kick-ass moms, but they perform really high and they often disconnect from their bodies
Mm,
and just push on. Culturally, it's reinforced too for
of
women to
course.
sort of
Yeah.
do that and just perform and
So, yeah.
not be really connected in our bodies.
Right. So just be sort of the woman of the people, like everything you can do everything kind of woman, right?
Yeah,
Like you can,
she does everything for
yeah,
everyone. She's
yeah,
super reliable, to go to her because she's going to get the thing done.
right.
I mean, I speak from experience, so
Yes. Yeah, I got that sense. And I totally understand. What is the relative proportion of women that are in those categories? Do you think sort
Mm.
of, population wide? Do you have a sense of that? It sounds like many of your patients fall into the second category, but do you have a
Yeah.
sense?
Yeah, it's hard. It's hard to say. I
Yeah.
don't there's really no data on it.
Hmm.
In my patient population, I would say it's about 50-50. I mean,
Okay.
I definitely see those women who have those high spikes in estrogen. So the type 1 woman who I'm talking about with the high chaotic estrogen,
Yeah.
she often has like really heavy periods. She's that woman who enters perimenopause and just is like, it's like a murder scene. And she often
Got
gets
it.
like an
Yeah.
ablation or something like that. But it's
Got it.
because estrogen proliferates the endometrial lining. And
Got it.
so when we have unopposed estrogen proliferating the endometrial lining coupled with low progesterone, women tend to have really heavy periods. There's also, moodiness and some inflammation and breast tenderness and stuff like that that goes hand in hand with those symptoms.
Right.
Women on the low estrogen side tend to just be a little bit more flat. Their periods are often scant or very light. So
Mm.
that's a good way for listeners to just kind of determine like what category they're in. Often with low estrogen, we'll have like dry skin. Sometimes later in the game, there can be vaginal dryness or discomfort with intercourse, low libido for sure.
Yeah. It's interesting how you frame it. So the second group that you mostly see are mostly these sort of high performers that have really kind of just pushed and pushed.
Mm.
What's the physiologic reason for it? Like they're pushing and pushing, they're coming out of their body. Why is their estrogen lower? Do you have a sense of that compared
Yeah,
to?
it's
Yeah.
HPA axis. It's stress. They
Got it.
often
Yeah.
have
Yeah.
other markers that show me they're under a lot of stress, or
Got it.
sometimes that they're underfueled. That's another thing I look for. So, along with low estrogen, sometimes they'll have low leptin. They'll have a high reverse T3. So it's like I
Got it.
always say your body loves you. It's trying to compensate, it's trying to reach
Always. Yeah.
homeostasis. And in
Hmm.
an effort to do that in a woman who's underfueled and performing at a really high level, she tends, that reverse T3 goes up as like
Right.
this body's mechanism of like, hey, I'm putting on the brakes for you. So you can slow down, slow that metabolism down so you don't need as much. And she often will gain weight as a result of that because her metabolism slows down. But these same women are often, yeah, it's this whole mix because the same population of women is often really low carb. And so I talk about this a lot in my practice because I want them to actually eat more carbs. So it's really good for their gut microbiome and for their
Sure.
hormones for this specific type of woman to eat more carbs. She often actually has a hemoglobin A1C that's a little like borderline, like
Mm,
maybe 5.6. It's like
interesting.
for years I was like, what's up? Like
Yeah.
all these patients have, this kind of borderline blood sugar where it's just sort of puzzling. And I mean, they're not overweight. They might be like 5 or 10 pounds higher than their ideal body weight, but they're not obese by any means. Uh, but they just have this surprisingly elevated blood sugar despite a very healthy diet. But what I find is they're eating really high fat inadvertently many times because they're gluten free and like really, on their health kick, trying
Mm,
to do their best.
hmm.
But they have limited carbs a lot and they're eating a ton more fat than they thought. And sometimes they're under eating protein. Oftentimes they're, prioritizing protein, kind of depends where they are. But the typical pattern is under eating protein, under eating carbs, overeating fat.
And you're seeing a mild insulin resistance
Yes.
within that.
Well, I think it's more driven by stress than insulin
Got
resistance.
it.
I think these
Yeah.
patients don't truly have insulin resistance because when they start eating carbs, their blood sugar comes down. It's more of a
Interesting.
stress response. It's their body like, ooh, I got to stay in survival mode, you know, bring up that blood sugar. It's driven, by high cortisol for
Right. So
sure.
the cortisol level is elevated
Yeah.
and that's increasing the blood sugar. It's not necessarily, and we know this, we know carbohydrates actually decrease our cortisol response.
Yeah.
Right. And so makes a ton of sense. And this, hits relatively close to home as I think about it. And so it's very interesting and so when you start putting them on carbohydrates, they tend to feel better. They tend to you also notice
Oh
that
my gosh.
their
They
A1C
tell
will
me
come
like,
down. Yeah.
in the afternoon, so many women are suffering through fatigue and just like slogging through, especially when they're moms,
Yeah.
and they
Yeah.
come home and they're just like, all you want to do is take a nap. It's really hard to mom when you're super fatigued.
Yeah.
Anyways, they start eating more carbs and women are like, oh my God, my energy is so much better. Yes, your energy is better. Like you need more carbs. Now we're talking, good complex carbs with fiber.
Sure.
I always encourage like your carbs should have fiber, though some of the pretty high performance athletes can do great on simple carbs after a workout, actually.
Yeah. Simple carbs such as like, what would you say? What would you, a good
I
example?
mean,
Like
what's my
juice?
favorite?
Yeah.
Yeah, juice would be okay. I mean, this honestly, if I'm totally transparent about simple carbs, I have a really hard time with them myself.
Yeah.
I
Yeah.
have a performance coach and she's like, eat rice cakes. That's your simple carb, rice cakes. And I'm like, ugh, I don't
They
know
don't,
about
they,
that.
they don't taste very
But
good. Yeah.
they don't taste very good. I'm
Yeah.
usually more of like when it comes to carbs, I have a hard time. I do complex carbs. I personally do like a lot of fruit and oats and potatoes.
Gotcha.
Yeah. So, I mean, rice would be a more simple carb. Juice, would be a more simple carb.
Right. Yeah. And we also know that carbohydrates before bed tend to help us relax and get that
Yeah.
cortisol down, excuse me. Right. And they can help people sleep better. So,
Yeah.
yeah, super interesting. Yeah.
It's such a nuanced conversation because there are also, I mean, I also have patients in my practice who are truly insulin resistant and
Right.
they do tend to be on the more overweight/obese side. And we know insulin resistance goes hand in hand with perimenopause and menopause and
Of
declining
course.
estrogen. I mean, that's a whole thing, building muscle, all that's super important. But for many of the like high performing females who are lifting weights and running or walking or doing whatever and really active, those are the patients who usually need more complex carbs and maybe simple carbs if you could figure out how to do that yourself. I don't know.
Gotcha. Gotcha. Okay. Well, there's one word that I wanted to ask you about with the gut that is relatively new for people, even clinicians, called estrobolome.
Yeah.
And I think we've kind of discussed maybe parts of this already, but if you can just maybe define that word. And I know we have a lot of these ohms now. We have the metabolome, we have the epigenome, we have the proteome, and et
Hmm.
cetera, et cetera. What is the
Ooh, the
estrobolome?
estrobolome
Yeah.
is my favorite because it is the microbiome's specialized unit for handling estrogen. And I think it is so cool because the estrobolome secretes beta glucuronidase, which is an enzyme that helps us to regulate estrogen reuptake in our gut.
Mm-hmm.
And so back in the day, I used to look at this test because you can get markers of it on a stool test.
Yep. The beta
And if I saw
glucuronidase. Yep.
high beta glucuronidase, I'd use something to kind of counteract that. But now I look at it differently, almost
Mm,
like reverse T3. It's your body trying to maintain homeostasis.
mm.
And so your body is so smart, the estrobolome is so smart that it can help regulate that estrogen level. And so, if you're going through menopause and you have a really healthy gut microbiome, it'll help you hang on to a little bit more estrogen.
Hmm.
Or if you need to get rid of estrogen, it'll regulate that way. But once you've got dysbiosis, that homeostasis is broken. And so what happens is women who are going through menopause tend to have worsening symptoms if they have dysbiosis because of that broken mechanism. So they have
Got it.
even lower estrogen levels.
So they're
And
getting
then
less reuptake, right, as a result
and
of
then estrogen more, high estrogen states like endometrial cancer. This is one point that I really love. But your risk for endometrial cancer is related to your gut
Hmm.
through the estrobolome. So if
Interesting.
you're hanging on to more estrogen and you're not able to excrete it as much, you're going to be at higher risk for the unopposed endometrial proliferation that happens with estrogen. And so you always want that balance between estrogen and progesterone. I always say it's very yin yang. And part of that balance gets affected by how you metabolize and balance things through your gut microbiome, specifically your estrobolome.
Hmm. And so beta-glucuronidase is an enzyme. Can you talk a little bit about how that works, and so that people understand what's happening? I know it's like sort of a conjugation like thing where estrogen can either be recycled
Yeah.
or it can be excreted, right? And
Yeah.
what are some of the
So
things that
let's
that
zoom
relate to
out
that?
and we'll look at
Yeah.
estrogen metabolism. So
Yeah. Great.
there's three phases of estrogen metabolism. Phase one happens through our liver through CYP enzymes. And so we can look at this through a Dutch test
Mhm.
and see if people are going down this pathway toward 4-hydroxy or 4-OH. That's the quote bad pathway. We don't really want a lot of that. That can lead
Okay.
to DNA damage.
Okay.
There's also a 16-hydroxy pathway. That's a little bit like indeterminate. We don't know for sure. A lot of people think it's related to growths like fibroids or cysts, or the 2-OH, 2-hydroxy pathway, which is favorable. So you really want to go down that 2-hydroxy pathway. That's why we tell people to eat broccoli, like eat cruciferous vegetables. That's really good for phase one metabolism.
Hmm.
That is also why we use a supplement called DIM. It helps with phase one metabolism. So just to be clear, DIM is a tricky one. I wouldn't go buy DIM, right? Like if you're listening, don't just start DIM. You
Sure.
don't want to use DIM if your estrogen is low. It will make it lower.
Interesting.
DIM
Okay.
can be a really great tool if you're on HRT and you want this like little bit of extra encouragement to go down the 2-hydroxy pathway. So I like to use DIM in my patients who are taking HRT.
Got it. Yeah.
And also, if you have hydrogen sulfide overgrowth, cruciferous vegetables might kill your gut. So that's where like eating a ton of broccoli and cauliflower and onions and leeks and garlic, like if that is causing a ton of bloating, a lot of women don't tolerate that because they need to first address their gut health. So phase one, CYP enzymes, cruciferous vegetables, DIM. Phase two goes through COMT methylation. And so that's where like magnesium can be really helpful, some B vitamins.
Okay.
And, depends on what your SNPs look like, but, COMT plays a big role here.
Mm-hmm.
And then phase three is really in your gut, and that's when beta-glucuronidase comes into play. And that's where your microbiome and your estrobolome makes a really big difference. And so if you're making a lot more beta-glucuronidase, you're going to reuptake the estrogen in your gut. If beta-glucuronidase is low, you're going to get rid of estrogen in your gut.
Got it.
And that's where sometimes we'll use calcium D-glucarate as a supplement to help with that. So there's like, I take DIM Detox, which has calcium D-glucarate and DIM in it. But now I'm sort of questioning, do I want calcium D-glucarate? I'm not really sure.
Yeah, as you were saying earlier, because it piqued my interest because I do a lot of stool testing as well.
Mm-hmm.
And I do see the beta-glucuronidase enzyme elevated. And when I do, I'm like, okay, well, they're likely, there's an inflammatory process going on, likely dysbiosis. But you also think about the liver as well and sort of, again, the reconjugation, not only of estrogen, but other toxic things as well, right? And so typically I would give calcium D-glucarate for this, but it sounds like it's more nuanced. Like it's not your first go around depending on the person and how they're kind of presenting to you.
Yeah. Now, I mean, I really think of it differently than I did a couple of years ago because I used to just give them calcium D-glucarate. But yes, now I'm really thinking about like, well, what's the homeostasis here? A good analogy too is like sex hormone binding globulin. Mm-hmm. When we see sex hormone binding globulin go up, my immediate reaction isn't, let me bring that thing down. It's, why is this high? How is this affecting your hormones? It's your body trying to maintain homeostasis. So what's the mechanism? I mean, often, sex hormone binding globulin will be really high in a woman on birth control pills. So it's like a whole other, we should talk about birth control pills in perimenopause. But so a woman, on birth control will have a SHBG that's really high, and it's her body's way of trying to protect her from the high synthetic estrogen she's getting in a birth control pill.
Part of the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode with Dr. Christine, check out our Tro-Z. Tro-Z is our comprehensive sleep formula. It contains 8 different ingredients that can help modulate the GABA system, serotonin, melatonin, and work on relaxing you, calming you down, helping you fall asleep, stay asleep, and wake up feeling rested. During perimenopause and menopause, sleep can be a big issue related to estrogen changes, progesterone changes as well, because progesterone works on the GABA system. So check it out at transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. Got it. Are there any other, looking at SHBG as a particular marker, are there any other reasons why you see it potentially being elevated and not in women that are on birth control? Are there other sort of instances?
For SHBG?
Yeah.
Yeah. Pregnancy is one. Any high estrogen state, birth control pills, sometimes oral estrogen oral estradiol will increase that. Not always. I tend to not see those high SHBG in women who are on HRT, bioidentical HRT, just more on birth control pills. It's going to also be high. Really high performance athletes tend to have a high SHBG.
I've seen that too.
My husband's a cyclist. His is high. I've got some other athletes who have a high SHBG.
Yeah.
Is it a vegetarian diet that will increase it too?
Yeah, I'm not sure. But I do know it could be an inflammatory marker as well, in the sense that if you're holding on to more testosterone, typically, right, because you're binding more, that's typically what's happening, is that there could be an inflammatory piece, there could be a gut dysbiosis piece. But I think you brought up the birth control thing. Maybe we should talk a little bit about that. So I wanted to talk to you about testing and corrections and things like that. But before we get there, a lot of women around the perimenopausal timeframe are being prescribed birth control pills. Maybe they have been on them when they were younger, and then they've been off for a while, or maybe they've been on the whole time. Some people have been. What is your sense of the role of birth control pills at all during this time frame, or is it completely misguided and we should be looking at like an HRT focus instead, or what's your sense?
Yeah, I definitely look at an HRT focus instead of birth control pills. So birth control pills come with risks, and they come with a lot more risks in older women.
Right.
And every time I get on stage and lecture, somebody comes up to me and says, I was the woman who got the blood clot on birth control pills in my 40s, because that is the answer that perimenopausal women get when they go to the doctor and say, I think my hormones are off. Like, typically, they're offered a birth control pill. Now, obviously, some women do need birth control pill. If you need contraception, I would really advocate for a vasectomy in an ideal world. If that's not an option, an IUD is a better option. It's not perfect, but it's definitely better than a birth control pill.
Right.
So birth control pills have side effects, the worst of which are stroke and blood clots.
Right. Yeah.
They also cause low libido and changes in mood. They shut off our ovaries. And when we're going through perimenopause, we don't want to shut everything down.
Right.
You want more estradiol. So it seems very unfair to me that women are not offered HRT, and it's scrutinized to this higher level. So I've had women tell me also, I can't take I can't take HRT because I had factor V Leiden. So factor V Leiden is associated with, increased clotting risk, especially if you're homozygous. But there's so many people, like, I don't know, probably 50% of the population has like a SNP at factor V Leiden. If they're heterozygous or it's really, really common.
Yeah.
And we never counsel women on factor V Leiden when they go on birth control pills, ever, even if she's 40.
Right.
I don't know anybody who's testing for factor V Leiden. I am, but I am also not prescribing birth control pills. So the point is, there's just a lot more scrutiny around HRT, which has a lot of benefits long term.
Right.
Like estradiol transdermally will not increase your risk of blood clots. It will often improve sleep, improve cognition. The gut health piece is really interesting. So birth control pills can also mess with your gut microbiome.
That was my next question.
Lots of other stuff too, like alcohol and exercise is great for your gut. Alcohol and antibiotics and birth control pills are bad for your gut. So, if birth control pills mess with your gut microbiome and increase dysbiosis, HRT actually does the opposite. Now, this is emerging research. We don't have awesome research on it yet, but it's coming out. And I will bet on it for sure. but HRT can be really helpful for the gut microbiome. And here's another one that I love is estradiol improves intestinal permeability. So the tight junctions are better with estradiol, which is so cool.
And that doesn't happen with synthetic estrogens
Oh,
at
heck
all,
no.
right? Yeah.
Yeah. It's like a synthetic derivative of estrogen. It is not, estradiol. So if a woman goes and gets her hormones tested and she's on birth control pills, there's like no estrogen and no progesterone that comes up.
Of
But
course,
what
right.
does
Yeah.
come up is the thing we can't test for, which is this synthetic ethinyl estradiol, whatever, is in
Right.
her birth control pill. And so,
And yeah.
it just looks like her hormones are flatlined, but she's got a lot of this synthetic estrogen derivative in her blood that's shutting off her ovaries.
Got it. Wow.
And
And so,
so, I
yeah,
mean,
go ahead.
there's a
Yeah.
time and place. Like for some women who have really bad endometriosis, like there might be a time and place for birth control. I'd never say never kind of thing.
Sure.
There's a place for it, but it is not a good treatment for women who are concerned about perimenopausal symptoms and want better sleep, better sex, better performance, better gut microbiome, better energy, better
It's a
mood.
Yeah, a lot of. I mean, so the synthetic estrogens themselves then have a propensity to increase your gut junction leakiness. So but if you're taking, but like estrogen itself is protective against them. So when you're going through perimenopause, you actually have an increased risk of leaky gut as well. Then
Yeah. I mean, estrogen disrupts your gut, or I'm sorry, birth control pills disrupt your gut microbiome, which the downstream effect is a more leaky gut or increased intestinal permeability. Whereas
Got it.
HRT helps your gut microbiome, and estradiol works directly on your tight junction, so improves your intestinal permeability and might balance out those big estrogen peaks or fix the low estrogen that some women have. And progesterone can help with the mast cell instability and a lot of other things.
Sure. I mean, this is, I think, a good segue to talk about treatment, right? So, I mean, I think you've kind of laid out the argument, and I think a very good one that HRT is something that maybe all women during the perimenopausal time frame, maybe all, not everybody, maybe, but I want to kind of delineate that a little bit. So, let's talk about HRT a little bit. How you think about it in perimenopause? What kind of testing you feel like is helpful, and what kind of testing is not helpful? And then maybe talk. I mean, we can also talk about the GI part of it, like the testing there that you do as
Yeah.
part of your workup, and how that maybe over time how you look at things. We can break all that down, but we can start with that framework. Yeah.
Yeah. So hormones. So in the perimenopausal woman, I test hormones. A lot of clinicians don't. The
Okay.
Menopause Society doesn't recommend that you do. So just be aware what I do is not what typical clinicians do, but I see a lot of value in it.
Okay.
It's just dependent on when you do it and how many data points you get. So I like to look at day 3 to 5 hormones when they're low and see like what's your estrogen doing at this lowest point. And then do it again in the luteal phase. So after ovulation and see like what's estrogen doing. And then you can, with more data points, like I at least get 2 markers, but I like to get more, especially when it comes to estrogen. The argument against testing estrogen is that it's all over the map with your cycle, which is true.
Right.
It's all
Right.
over the board. But that's why you get more than one data point. That's also why you can do daily testing. So there's some upcoming tests, like Dutch test will do a cycle map. There's also a test. It's called Empower. I literally have it on my desk here. I haven't used it yet, but it also will do, give you that kind of data so you can see, what your levels look like throughout your cycle. So there are ways to do that. But
so when you're doing it like with data points throughout the cycle, is it you're doing it daily throughout the cycle, like something like the Dutch test or this other test?
Yeah, the Dutch cycle map is you pee on a card basically every day of your cycle, and then you can see the path that happens. I mean, we know, in the first half of your cycle, estrogen is going to start to increase, and then it increases enough where you get this LH surge and you ovulate. In the second half of your cycle, the corpus luteum makes progesterone. So you see this increase in progesterone. And so in a perimenopausal woman, I would say almost like pretty much universally, perimenopausal women have this decline in estrogen. And I say perimenopause is like the inverse of puberty. Puberty's happening, hormones are all over the map, but they're like increasing, and perimenopause, they're all over the map and decreasing, and sometimes they're just low overall.
Right.
So, doing testing will help us identify that, and will help us identify also, like, does a woman have really low estrogen, or is it all over the map? And then symptoms are really the most important. And the amount of flow, like how heavy your period is, can be a very helpful indicator of what's going on. For women with the IUD, it can be trickier because we don't really know. Sometimes they're not ovulating. Very often they're not ovulating. So I'll check their labs like 10 days apart. But, symptoms are a huge part of it. Of course, labs are not the primary way to test for perimenopause. There is no definitive test for perimenopause, but I think labs are critical, and also because I have coined this term, the unmasking effect in perimenopause. And what that means is perimenopause is a time when any underlying health condition gets unmasked. And so it's
Mm,
really important to look not just at gut health, but also at thyroid. Sometimes we see a big increase of autoimmune disease in menopause. And, part of that's the unmasking effect. And
mm,
so, as we're looking through labs, I like to get really comprehensive labs so we understand, is this the picture of a woman who has low leptin and a high reverse T3? Maybe she also has subclinical hypothyroidism. She's got low estrogen, low progesterone, and nutrient deficiencies. We're looking at methylation, magnesium, what's her B12 and folate and all that kind of stuff. And then, or we might see this picture of somebody who's actually got really true insulin resistance. Her insulin is high. This is not my typical patient, but I still see them for
right.
sure.
Sure.
But, she has high insulin and, maybe she has high cortisol too. I mean, that can happen. We see, both sides of the coin there. I'm looking not just at estradiol and progesterone in the labs. We look at DHEA, pregnenolone, progesterone, estradiol, and then testosterone we haven't really even talked about. But a woman who has a woman has testosterone
Yes.
and the reference range goes for free testosterone literally is like 0 to 5. It really depends on the lab. But I'm like, why does the reference range go to basically 0? It's like 0.2.
That's crazy. So it's a
But
0 at the bottom.
how is that okay? A woman's estrogen, like if you were to measure unit per unit, estrogen versus estradiol versus testosterone, a woman actually has more testosterone than
Yes.
estrogen.
Yes, I know this.
So,
Yeah.
a lot of times that's forgotten about, but I'm definitely looking at free and total testosterone, SHBG, the full thyroid panel, thyroid antibodies, all
Yeah.
that kind of stuff. So
Yeah.
I
Yeah.
think really comprehensive testing is important, though on its own, it doesn't really identify perimenopause. And there's some better diagnostic tools that we can use, like, a Dutch cycle map and things like that are forthcoming.
Understood.
So that's testing. What was the next part?
Well, that's the first part. Let me ask you a couple things about that because that was really
Yeah.
comprehensive. I think the idea of unmasking is really interesting, and I wanted to just take a minute to talk about that because I think maybe you can describe what that would look like in a clinical
Yeah.
perspective, right? Because I think giving some examples for clinicians out there, I've seen this in my own practice over the years, but maybe some people haven't. So tell me what that looks like in some of the patients you've seen over the years and what that might present
Yeah.
like.
I mean, so many 40-something women are having a bit of a health crisis and they're not getting a lot of great answers. They're getting birth control pills and acid blocking medications. And part of the reason behind that is because as we lose hormones, we lose resilience. And
Mm,
any of the underlying health issues we have, we can't ignore them anymore. They just become to a point where you can't not look. They're going to, cause symptoms. So a lot of the women I see are struggling with an autoimmune disease.
mm,
Hashimoto's is super common.
sure.
Sometimes other things like inflammatory bowel disease or something like that. They are often struggling with hypothyroidism in addition to low hormones associated with perimenopause, so estrogen, progesterone, testosterone.
Mhm.
Um, Other hormonal kind of symptoms, I mean, it's tricky. Like, there's other things that come up for sure between
Right.
endometriosis and, things like that. But there is, any kind of underlying issue is coming
Right.
forward. And then gut health is a huge one. Like we see worsening of IBS symptoms, worsening of IBD symptoms, bloating, all that. So
Right.
the symptomatology around perimenopause and menopause, I mean, it said there's like 50 plus symptoms. The reason
Right.
for that is because of the unmasking effect. It's because there's all this other stuff going on. And that's where, back to what I said at the very beginning, it's not just hormones. It's so much bigger than just hormones. Hormones play a really important role. But when I approach in my clinical practice, I have a 3-pillar framework. So number one is address the root cause. And often that's related to gut health, but
Mm,
sometimes it's
mhm.
also like autoimmune disease, inflammation, toxin exposure, mold exposure, heavy metals, whatever it might be.
Sure.
Number two is optimize hormones. And so that's optimizing, your sex hormones, your thyroid hormone, insulin levels,
Mhm.
cortisol. And number three is building resilience. And so that's where I work with patients to really like dial in good lifestyle habits like a protein centric, high fiber nutrition, strength training, walk, movement, sleeping, which definitely there's like crossover between perimenopause and hormones and sleep and even root cause issues in sleep,
Yeah.
stress, peace, mindset, and then low tox living.
I love it because I think I love that I love the order of that. And I talk about this all the time with patients as well. I work with a lot of, with a decent amount of guys doing hormone optimization, right? And what I always talk about with them is that we can't start working on your testosterone, your growth hormone, your thyroid, et cetera, until we work on some of those, quote unquote, root causes, like your underlying foundational biology, your vitamins, your minerals, your nutrients, your toxic load, because that's going to have a huge effect on your hormones as well, as you've already described.
Yeah, totally.
Yeah. One thing I wanted to ask you about with HRT and looking at labs, and you mentioned like getting a baseline or trying to get, with data points over like multiple months. As you are working with somebody and doing HRT, is it something that you're doing from there? You're rechecking labs over time, or is it something that you're just kind of looking symptomatically and how they're feeling, depending on what kind of data points you saw initially?
Yeah, no, I'm a lab girl.
Okay,
I like labs.
cool.
I also am a risk versus benefit girl. Like, what is the risk of getting some blood work? I mean, there's really not. Let's get some data. I mean, right,
Yeah,
there's some financial risk, but we can mitigate that.
sure.
Yeah, so I like to look at labs and I like to use labs to titrate their dose, so
Got it.
just like we do
Okay,
with thyroid. And really, this brings up a good kind of point too with thyroid. I mean, if somebody has hypothyroidism, we give them thyroid medication. If somebody is perimenopausal and deficient in estrogen, we can give them estradiol, and then you look at labs to balance it. Now, you can't use FSH and LH like you use TSH for
sure,
thyroid,
sure.
but we can look at estradiol levels in the blood work, look at progesterone, we can talk through symptoms, we can understand bleeding and what the
Yeah.
flow looks like, what your cycles look like, all that kind of stuff.
Cool. And so, I mean, maybe just like a couple notes on controversy here a little bit, just for those that are listening. And many of the people that are listening already have a pretty good framework of understanding HRT and why it could be helpful. But why is it still so controversial, Christine? Why do you think it's still at that level? I mean, it seems like it might be changing a little bit. Sometimes I think it is, and then other times I'm like, no, nothing's changing.
So
and
HRT and or testing or both?
HRT, I would say
Yeah,
both.
HRT.
But I think HRT maybe is the bigger of the two, right?
I mean,
Yeah.
largely it's because the Women's Health Initiative study that was published in 2003 is a
Yeah.
big media blitz, Time Magazine, like all the things, causes breast cancer. It doesn't cause breast cancer. It it can grow. It's proliferative. So estrogen, if you have an underlying breast cancer, could grow it. So you need to be careful about that. I always get mammography before I start patients on HRT.
Okay.
I wish we had a better option than mammography, and there are some coming up,
Yeah, there are.
QT imaging I'm really curious about, but that's what's accessible. That's what we've got right now. That said, endometrial cancer or uterine cancer is a risk. And so women need to be really cautious about that. That's why we always use progesterone with estradiol. However,
Together. Yeah.
as we talked about with beta glucuronidase, like that will depend on your gut microbiome and beta glucuronidase and your estrobolome, because you might be somebody who needs more progesterone and less estrogen if you're, hanging on to it. So, that balance is really critical. But yeah, I mean, the Women's Health Initiative just was a huge setback in women's health because doctors just stopped prescribing about it or stopped prescribing it and talking about it. I didn't learn anything about it in residency. I mean, I was a family medicine resident. Did you learn anything about hormone replacement?
No, there was nothing. I mean, I was in, no, as an internal medicine doc, there was talk about the Women's Health Initiative and how, that HRT, that's actually when I was in medical school or residency, that's when they started taking everybody off HRT because they thought it increased their risk of the cancers, the strokes, the thromboembolism, things like that. But they were using all the synthetic progestins and estrogens during that study.
Yeah. Right? The other big, huge piece is like, if you look, the reanalysis, I think was in 2013, 2011. The reanalysis did not get anywhere near the press that the original data got, but the reanalysis basically showed like, oh, actually, I think the estrogen arm was protective against breast cancer, but nobody's really talking about that. But the hormones that were being studied are very different than the hormones we use now. So Maren was, from a pregnant horse's urine. And while honestly, I think it's better than nothing if you need estrogen, estradiol, transdermal, bioidentical estradiol that we use now is very different. And same thing with progesterone. What was studied in the Women's Health Initiative was a synthetic progestin. What we use now in HRT is a bioidentical micronized progesterone. Very different risks. There's a French study looking at potentially that progestin was associated with maybe a slight increase in breast cancer risk. But the reality is we just don't have a lot of really awesome data. We do have some data. And, it's a risk benefit decision. I mean, it's not right for every single person. Um, we should talk about vaginal estrogen, side note.
Sure. Go for it. Yeah.
Um,
Yeah.
yeah, but it's really doctors are undereducated on it. There's just not a lot of awareness
Yeah.
around it. And that's why they're more comfortable prescribing birth control pills because they're
Right.
educated on that. They've used it for years. They're very comfortable prescribing it because they've always done it. But HRT is just different. They're not comfortable prescribing it. They don't really know how. I
Mhm.
do think it's changing, but I kind of live in a bubble of
Sure. I get it.
there's a lot
Yeah.
of hormones
Yeah.
in my world.
I understand. Do you want to talk
Like,
briefly about vaginal estrogen just
yeah,
to kind of
vaginal
throw that? Yeah.
estrogen
Yeah.
is a really great tool. It's one of my favorite things to prescribe to any menopausal woman. But I think, one thing that doesn't get talked about is as women go through menopause, they actually experience a change in their anatomy. So the vulva changes and they can get certain kinds of things that will decrease sexual function over time. So it's a really big deal to maintain your anatomy.
Mhm.
And also, it's a great tool for helping prevent UTIs, but also helping the urinary bladder. So I've had patients go on vaginal estrogen and now they're able to sleep through the night because they don't have to wake up to pee. It
Mhm.
helps tone the urethra
Mhm.
and it's very low risk. It's like you could actually use it if you had breast cancer. However, women with suspected or confirmed gynecologic cancer should not use vaginal estrogen. But outside of that, it's like a really safe, simple intervention with no money behind it. So you might not learn about it. Like,
Yeah, I got it. Yeah.
nobody's
So
making commercials.
right. So typically you'll have people on like an estradiol patch along with vaginal estrogen together, or is it some people that you'll just do vaginal estrogen on its own?
It depends. If you're not a good candidate for estradiol transdermally or systemic, I would argue that the vast majority of women should be using vaginal estrogen at least.
Got it. Okay.
So you can use them together. I use them together all the time.
Mhm.
So local vaginal estrogen versus systemic
Mhm.
estradiol.
Mhm.
Yeah, you could use either. You could use them both together.
Cool.
The pharmacy will sometimes give you some pushback. So we have to explain to the pharmacy, yes, we meant to do that.
Yeah, I understand. Yeah.
They're very
Oh,
different.
yes, understood. Okay, so let's go a little bit along the side of of gut testing, GI testing, and how you think about probiotics, prebiotics. Just what's your framework there? I know this is kind of a big area that you play in. So, what
Yeah.
kind of testing do you typically do, and what are your major interventions overall
So my
here?
my favorite 3 tests would be a SIBO breath test because bacterial overgrowth is very common.
Hmm.
There is also one that tests for hydrogen sulfide, the TrioSmart one, so I like to do that sometimes depending on the patient. Uh, I'll do urine organic acid testing a lot. I like
Hmm.
to look at that first page, especially when it comes to fungal overgrowth. So
Hmm.
a lot of times patients are dealing with fungal overgrowth.
Hmm.
Which is really what people call candida or yeast.
Right.
And I'll do stool testing as well. So that triad tells me a whole lot about what's going on with the gut microbiome, along with talking to a patient and understanding what her symptoms look like. But from there, we can look at, is there dysbiosis? Is there overgrowth of fungal species? Is there overgrowth of Clostridia? Um, is there H. pylori? Maybe there's a parasite. I just had a patient last week who has been struggling with digestive issues for, a couple years.
Hmm.
And we identified on stool testing that she had Clostridium difficile. And so I
Hmm.
sent her to Quest. I'm like, go test this at Quest. Let's just make sure. Indeed, she's got C. diff. But, in the conventional realm, I think, just nobody was checking for that because she wasn't like the typical patient who would have C. diff, But
Right.
yeah, I
Right.
mean, there's all this different collection of, whatever
Yeah.
gut infection, whatever flavor you have, and you could have several. Sometimes I get patients who I'm like, oh crap.
Yeah.
Well,
No
literally.
pun intended.
Yeah,
Yeah.
no pun intended.
What crap?
Yeah, that sucks, but we got you. Like, I'm glad
Yeah.
you're
Yeah.
here. Let's
Yeah.
let's
Yeah.
let's go. So
Yeah.
I use a combination of prescriptions and herbals. I like to my gut framework is like remove and replace. So remove the gut infections. So that might be prescription medications like Xifaxan or antifungals.
Hmm.
Also, likely will be some sort of herb. Remove things like gluten and alcohol, some of the gut irritating foods, remove
Sure.
ultra processed foods, things like that.
Hmm.
I don't generally put people on like a really restrictive diet, but if they have histamine issues, we might limit some things like sauerkraut and alcohol or
Right. Some
something like
histamine
that. So
related
just
foods.
kind
Sure.
of,
Yeah.
yeah, it
Yeah.
just depends. Remove, I also, talk to my patients a lot about just the psychology and the emotions behind it all. So remove that like self-criticism or that self-critical voice. I think that's a really important point too.
Mm.
And remove toxins because those are going to disrupt your gut microbiome as well.
Yeah. I
And
was thinking
then,
about all those
certain,
estrogens in the water. So
yeah, totally. Yeah.
yeah.
And like, that's a whole other story. Like xenoestrogens in your environment, these are bad estrogens. Estradiol is a good estrogen. So, good and bad, but most of the negatives around estrogen are related to, chemicals and plasticizers that resemble estrogen or endocrine disruptor chemicals. So, when we're talking about gut though, like, remove those big offenders and then replace digestive enzymes. Some women need more digestive enzymes or they need some more digestive support. Those same women who have like disconnected from their body and have low hormones tend to have low digestive enzyme function and low stomach acid
Makes sense.
because they're super stressed. So, replace enzymes, sometimes replace stomach acid, replace hormones, HRT. That's a big one I put in there.
Of course.
So
Yeah.
that's sort of the framework I use. And then, re-inoculate. I like to use spore form probiotics. I'll, potentially layer in prebiotics later on, but I don't use a ton of prebiotics. I just really encourage patients to eat more fiber.
Yeah.
Eat more fiber, whole fruits, things like that.
What's your take on selective versus non-selective prebiotic fiber? There's a little bit of controversy there, like in the sense if you have like some of the products out there for some of the companies that you and I like will have these sort of selective prebiotics versus non-selective. You take like acacia fiber or psyllium husk or something like that. Do you have a major distinguishing aspect of how you think about it clinically or not really?
I don't. Can you school me on that?
Well, the idea with the selective fibers is that they're supposedly only allowing certain types of bacteria to grow compared to the non-selective ones, which are letting everything grow kind of deal. So in general, when I have somebody that has bacterial overgrowth, if I'm going to put them on anything, it's going to be more of like a selective prebiotic fiber, something like we would use from like, Mega Prebiotic or something like that from like Microbiome Labs or something like that, as opposed to putting them on acacia or psyllium or something like that. But I think it's still controversial. I don't really think we have a good sense of whether that really matters or not. But I tend to be similar to you in the sense of trying to get it from the food, but also not overdoing it on fiber as well, especially if they have bacterial overgrowth and fungal overgrowth and things like that, because I do worry that you're going to get this sort of, the response that, maybe everything will grow, even if we're trying to, remove that kind
exactly. Yeah. Yeah. And I mean, the first thing most people do when they have a gut infection or when they have gut symptoms is eat more sauerkraut.
Yep.
Take a probiotic.
Yep.
What's the other thing they do? I mean, those
yogurt,
two things.
Yogurt,
eat a lot of yogurt, right? And all of those things can actually be the opposite of what you want to do. Like if you're somebody who has a lot of histamine issues, you're going to worsen that. If you're somebody who has bacterial overgrowth, that traditional probiotic is going to make it worse. So, this is where, like, if you've tried those things and you're discouraged, that's where working with a clinician can be really helpful. The other big one is like, they're like, I took out gluten and I didn't feel any better. I'm like, great. Unfortunately, we have to do a lot more than that. Like we've got to take all the logs out of the fire. And that's the same thing with hormones and HRT and perimenopause. Like menopause. I started HRT and I don't feel better. I'm like, great. And we have to do all this other stuff. We got to address, like you've unmasked all these other issues. So we need to address all the other underlying issues.
Right. The unmasking is a big part of it. And I think it's a huge important piece that you mentioned there, which is the framework that you use. It's not just about HRT. It's not just about looking at even the quote unquote root causes. It's all looking at things together and then working with clinicians as we do, knowing that everybody is going to be different. And I think this is a gripe that I have, and I know you do as well, when you see like online advice about adding in fermented foods or, or starting this sleep protocol, from somebody that's not a clinician, that doesn't see people and that, gives you advice. It kind of drives me crazy. I'm sure it drives you crazy too. So we have to deal with the patients on the other side of it saying, I need this. I'm like, no, you don't. So
one of the things I see is people who are on very restrictive diets, because they've read a book, and that's honestly, it's like, that's the easiest thing to give somebody. If you're writing a book and you want to give them like an easy win, you give them a special diet. But like, we don't, it's a special diet. It doesn't have to be that complicated. Eat real food and more of it. And if you have gut issues and autoimmune disease, don't eat gluten. And, don't eat ultra processed foods and like limit alcohol. And, I mean, I don't think we need to follow most people don't need to follow, autoimmune paleo or some of those really restrictive diets. It can cause a lot of stress.
They can.
Again, I mean,
Yeah,
there's a time and place. Like this isn't a never say never kind of thing,
of
but it
course. Yeah.
just, yeah.
Yeah, I love that. I love that. That's more of your framework overall. And I think a big thing that you kind of gave me today as like a little bit of nugget there is these two different types of women that are going through perimenopause, and that the change in hormones like very different, and especially because I know a lot of the high performing type as well, and like the mild insulin resistance and
Hmm.
quotes the elevated cortisol. So that was really cool, Christine. But at the end of the podcast, which we're at the end now, I ask everybody the same question, and you've already discussed a lot of things that might apply here. But the question we ask everybody is, what are 3 ways that we can all live smarter, not harder?
Mm.
And that's the name of the podcast, the Smarter Not Harder podcast.
Yeah,
And
totally.
and this could be in anything you discussed today, or it could be in other kinds of things that you think that might be helpful. But what are 3 simple tips that you think all of us can do to live smarter, not harder?
I love this question because I think about it often in terms of strength training. Like you'll see me in the gym 3 or 4 days a week lifting weights. And you'll see me resting in between those days and trying to take it easy. So I think when it comes to building muscle, that's really key as we age. It's key to our, metabolic health. It's key to feeling strong and more confident. I
Mhm.
think it helps with emotional health. I think it helps with obviously your structural, framework and joint pain and things like that. But anyways, smarter, not harder. Like lift weights 3 or 4 days a week.
Okay,
Make
cool.
sure you're getting rest.
Okay.
I think the diet piece is another one. Like smarter, not harder. Eat more protein, eat more fiber. You don't have to be on a super restrictive diet. There's definitely some foods to avoid. Uh, Alcohol would be a big one. I think a lot of people I see are, they're gluten free, they're dairy free, they're sugar free, they're like
Yeah.
a lot, like whatever. They're not eating any grains, but then they drink a lot of alcohol or a decent amount. Maybe it's not even a lot, but it's a glass of wine every night. Wine has like 0 health benefits. So don't
Yeah.
fool yourself. I mean, if you want to have a drink every once in a while, go for it. But like that's a smarter, not harder concept right there. Yeah.
So if you want to have like a bonus, or maybe you're done, that's cool either way.
We can
So
leave it there. I'll call you later if I think of something.
that sounds good. Those are great overall. I think the rest part is such an important piece too, that many of the people that are listening, the clinicians and the people that are just go, go, go. And it's hard for us to all, rest. And many of us are type A. So I think it's great that you mentioned that as well. So, Christine, thanks so much for spending some time with me today and going through, your expertise, which is super cool. And, I'm really excited again that you're going to be speaking at our symposium, the Health Optimization Medicine and Practice Symposium, October 17th and 18th here in Chautauqua in Boulder. It's a fantastic place. The leaves will be changing. We're going to have 2 days of speakers. Christine, you're speaking. Dr. Elizabeth Yurth from Boulder Longevity, she'll be there as well. We're going to have Thomas DeLauer, who's coming from California, a good friend, is a great educator. We're going to have multiple other great speakers as well. You can check it out at homehope.org. And Christine, tell us where we can learn about more about you. And I know you are taking patients. You have a virtual practice. Tell us a little bit about all of that.
Yeah, so I see patients in Colorado, Michigan, and Texas. My website is drchristinemaren.com, and I am mostly on Instagram at drchristinemaren.com.
Awesome. You rock, Christine. So I hope you have a good day going to your concerts, picking up all of your children and all the things we talked about before.
I'll
we
try
got on
not
the phone.
to forget anyone.
Yeah, that's always a question with my fourth, but that's the breaks of having the fourth kid. If they eat, if they get to where they need to go,
Exactly.
it's a blessing. So
that's why I am who I am. You know that I was the fourth.
Oh, I didn't realize that. Okay, cool.
Yeah, I was the little one who took care of herself.
I love it. Well, you have a great day, and hopefully I'll see you non-virtually in person soon.
Sounds good. Thanks,
Take
Scott.
care. Thanks so much for tuning into another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. This episode was a fantastic one with Dr. Christine Maren. We talked about perimenopause, the gut, the estrobolome, which was a new word for many of us, how to test, how to correct, how to think about things in a framework, nutrient gut optimization, hormonal optimization, and so much more. If you like this podcast, don't forget to like and subscribe below so you never miss an episode. And check out our Home Hope Symposium. Go to homehope.org and check us out. Come join us October 17th and 18th in Chautauqua in Boulder, Colorado, a beautiful time of year. So many different great and amazing speakers. We hope to see you there. Take care.